Coming to the ECG in normal children. So, among children we have been categorized ECG in various age groups, like at birth, within 1 year, 1 to 5 years, within 2 years, up to 5 years, up to 10 years. So, there are various changes in the ECG up to 10 years and up to puberty. So, at birth, what are the different changes in ECG we have seen? That is right axis deviation we are seeing, then sinus tachycardia. See, the normal heart rate up to 1 year of age is around 140 to 160 beats per minute. Okay. So, the normal heart rate up to 1 year of age is around 140 to 160 beats per minute, and by the time the age grown up, the heart rate reaching up to 60 to 100, and it will reach up to the adult level up to 60 to 100 till the age of 10 years to 12 years at puberty. Okay. So, what are the other ECG changes will be seen, which is quite normal at birth? The dominant R waves in lead V1. Okay, the dominant R waves in lead V1, then subsequently deep S waves in V5 and V6. Okay, then T wave inversion in lead V1 to V2, particularly the right sided leads. Okay, so the T wave inversion is quite a normal thing at birth, and it is up to, I think, around 8 years and 10 years it will be seen, and it is quite juvenile. T wave inversion is a normal finding in case of ECG finding in case of children. Okay, at first year of age, what are the ECG changes seen? Same, sinus tachycardia, then right axis deviation till persists, then same dominant R waves at lead V1, the deep S waves which are usually seen at birth is not seen at around first year of age. Okay, these are not seen, while the T waves is still inverted in V1 and V2. Okay, next, by the time of second year, what are the different ECG changes? The right axis deviation will be shifted to normal axis now. Then the S waves are more prominent than R waves in lead V1. Okay, then T waves are still inverted in lead V1 and V2. Okay, when by the time of fifth year of age, what are the different ECG changes seen? The QRS complex is absolutely normal, then the T waves are still inverted. Okay, in V1 and V2. So, the why the T waves are inverted in V1 and V2? See, this is quite normal because of right axis dominance. Okay, the right axis dominance, why it will be happening? Because in case of infants, in case of neonates, the right axis dominance and right axis deviation is usually seen because of the that I have been already explained, because of the pulmonary hypertension and the high resistance of the pulmonary circuit. The right ventricle has to work more, and because of this right axis deviation will be seen. But after birth, the ductus atrosus, which will be usually closed, and the pulmonary artery has been patent. So, the pulmonary artery resistance will be decreased, and after that the right axis deviation will be shifted to normal axis deviation gradually. So, because of this reason, why in case of infants the right axis deviation and will be seen, and the T waves are still inverted while growing up to 10 years. Okay. So, by the time of 10th here or up to puberty, normal adult ECG will be seen. Okay. So, the right axis deviation, that two important points here is right axis deviation is seen up to 2 years of age, and T wave inversion seen up to 8 to 10 years. Okay. These are the normal findings in case of normal ECG in case of children, right. Now, we will discuss regarding common lead placement errors. Okay. Now, we will discuss regarding the most common lead placement errors. The most common lead placement error is the right arm and left arm reversal. The most common lead misplacement error is the right arm and left arm reversal. Okay. So, in that case the technicians and the physicians may reverse the lead of the right arm with the left arm. So, in that case what will be the result? Usually the AVR in the normal ECG is negative, starting from P wave to the T wave, everything is negative in normal ECG, but in case of that reversal the AVR becomes positive. So, all the waveform of the AVR becomes positive. And the second point is that in the lead one which forms the AVR, it is the normal mirror image of that AVR will be found. Okay. So, in lead one, mirror image of lead one will be seen. Okay. Now, the most important point to highlight here that left arm right arm reversal may show similar features of the ECG having normal dextrocardia. The left arm right arm reversal may show similar ECG features having dextrocardia. Okay. So, now we will see one ECG. This is the right arm left arm reversal. As you can note here that the AVR which is usually negative in normal ECG, it is positive here. Okay. And the lead one is the mirror image of the AVR. So, it is negative here. Okay. Next, what other types of limb lead displacement errors will be found? The second one is arm and leg limb displacement or reversal. So, in between the arm and leg, it is that if the reversal of the leads will be done, then it is very difficult to identify or difficult to interpret in the ECG that it has reversed, the leads has reversed. So, in between arm and leg limb displacement, it is very difficult to access or interpret. So, but in that case, if right leg lead with the arm leads will be reversed, then it will be little bit easy. So, although between the arm and limb lead leg limb leads displacement is very difficult to access, but if the limb lead displacement between right leg and the arm will be done, then we can diagnose or we can interpret through ECG. Okay. right? So in that case, what will be the result? It produces pseudo asystole. The ECG shows pseudo asystole, particularly in lead 2 and lead 3. Okay. So let us discuss one by one where this kind of asystole or a low potential will be found. Now, one case, if right arm, right leg will be reversed, then what will happen? If right arm and right leg will be reversed, then what will happen? Suppose normal Einthoven's triangle, this is right arm, this is left arm, this is left leg. What is the role of right leg? It only as a neutral lead. So it has a only neutral role. Okay, it is only a neutral lead. So if that right arm and right leg will be displaced, then what will ultimately happen here? Ultimately, this will happen. Now, this is right leg, this is left arm, this is left leg. Okay, the right arm will be shifted to right leg area. Okay. Now tell me, what is that lead normally? This is lead 2 in normal ECG. Okay, and as one common thing is that if that reversal is happening, the ECG features show asystole in lead 2. Okay. So how the ECG will be seen? Let us discuss. Now see here, where the right arm and right leg reversal has happened. See here in the lead 2, this shows zero potential or very minimal potential, pseudo asystole. Rest everything is normal. Okay. Now, if the second scenario, if left arm with the right leg reversal happened, then what will happen? If left arm and right leg reversal happen, then what will happen? Again draw the Einthoven's triangle, right arm, left leg, this is neutral right leg. If that will be reversed, then what will happen? This is normal ECG. Okay. The left arm, right leg reversal. Okay. So what will happen to that Einthoven's triangle now? Now this is right leg, lead will be coming here, this is left leg, this is right arm. So this normal ECG, in case of normal lead placement, this records lead 3. Now this is lead 3. Okay. So here the lead 3 records between right leg and left leg, which is in the lead 3. So that's why the lead 3 shows pseudo asystole. Okay. Now we'll see that ECG how it looks like. See here, in lead 3, zero potential or low potential ECG will be seen because of left arm with the right leg displaced. Okay, so that the left arm, left leg, which is normally lead 3 will be displaced by right leg with the left leg. Okay, this is normal, this is displaced leads. Okay, so this is all about the lead displacements. One important point to highlight here, if left leg will be reversed with the right leg, then what will happen? See, left limb is a normal lead which will be usually produced, or see, is the potential difference will be found or recorded in between left arm and left leg and right arm and left leg. Okay, so if that left leg will be reversed with the right leg, usually there is no significant change in ECG, in any discriminative significant change will be not seen, or you cannot identify the lead reversal between left leg and right leg. So, left leg right leg reversal won't make any difference in ECG interpretation. Okay, so either you will not know, or it will not show any significant change, any ECG interpretation. Okay, now coming to precordial leads. Placement errors. Okay, the commonest error in case of precordial leads placement error which will usually seen are to either place one or more electrode in the same intercostal space. So, the commonest mistake done by the technicians are to place one or more electrode in the same intercostal space, which usually not allowed in the designated spaces. And the second is either the electrodes are placed too high or too low, which are not in between the designated intercostal spaces as assigned. It is either placed too high or too low. Okay, not at the designated places. Right. So, what will happen to the recording of the ECG if low placement of precordial leads will be placed? What do you mean by low placement? If it will be placed more than 5/5 intercostal or 6th intercostal space, it will be called as low placement of the precordial leads. If it will be placed high placement, that means beyond second or first intercostal space, or high placement of the intercostal spaces and third intercostal space in between second third intercostal space, then it will be called as high placement of the precordial leads. So, what will be the common finding or common ECG will be, which will be recorded in the low placement of the precordial leads? The progression of RAS will be seen. Then if high placement of precordial leads will be placed, then what will happen? It may produce RSR pattern. If high placement of the precordial leads are placed, then it may produce RSR pattern. Then in aberrant switching of electrodes for example, in between B1 and B3 may produce abrupt change in QRS complex. Okay. So, invariant switching of the electrodes between, suppose let us say in between V1 and V3, it may produce abrupt changes in the QRS complex. Now, we will see one image or the ECG finding. See what does exactly it will happen, or what is the ECG interpretation here. See here what exactly happen, abrupt increase in R wave will be seen here. So, in this ECG, abrupt increase in R wave in B2, and then you can see here both R waves and S waves are dominant in case of B5. So, in B5 dominant RS complex in B5. So, this suggests B2 B5 reversal. So, this suggests B2 B5 reversal, which will be seen here, the B2 and B5. Okay. So, after correction of the placement of the leads, then this is after post correction, right. The B5 is corrected and B2 will be recorded normally and B5 will be correct. In ECG, the different artifacts in ECG is due to loose leads, then SC noise, then muscle tremor or movement, okay. It may be due to electromagnetic interference, like wearing smart watches. Nowadays we are using smart watches, metallic instruments, electromagnetic interference. So, we are advising the patient to remove all the electromagnetic gadgets and airdrop instruments which detects the location, okay. So, electromagnetic interference, echo distortion, during transcutaneous pacing, okay, echo distortion. And most commonly we will find if you put an electrode on the atrial, radial artery particularly, okay. If you put a electrode over the artery, then it mimics like ventricular tachycardia. If that pulse rate is high, then you have to look after that whether it is particularly it is ventricular tachycardia or it is an artifact due to placement of the lead over the artery. Arterial pulse tapping artifacts. This is the most important finding. It is due to placing of the electrodes over radial artery, okay, placing of the electrodes over radial artery. Now, we will see one image. See, irregular baseline with high frequency artifacts that mimics the ventricular tachycardia. Here underlying QRS complex is intermittently seen, but there is no consistent wide QRS morphology. So, in case of ventricular tachycardia, the patient has been pulseless activity. So, simultaneously you have to look after for the pulse of the patient. In case of ventricular tachycardia, which is a normal pulse which will be seen in case of muscle movement, but in case of ventricular tachycardia no pulse movement will be seen, and the patient is unstable, particularly maybe syncope or maybe fainting episodes will be usually seen. The QRS duration is wide enough, whereas the QRS complex is not so consistently wide or very much not mimicking the property. So, it is a variable appearance QRS morphology, but here the QRS morphology is consistent. Okay. So, these are the different findings which will differentiate between ventricular tachycardia and muscle movement artifact that mimics ventricular tachycardia. For first, you have to look after for the pulse of the patient. In case of muscle movement artifacts, the pulse is usually present, but in case of ventricular tachycardia the pulse is absent. Okay. The patient is stable here, usually the patient is unstable in case of ventricular tachycardia. So, these are the different differentiating features, whether it is due to muscle movement artifact and ventricular tachycardia. Feature or another abnormal ECG pattern, that is WPW syndrome, otherwise known as Wolff Parkinson's White syndrome. Okay. Wolff Parkinson's White syndrome. So, what are the different features of this Wolff Parkinson's White syndrome? See, normally the SA node travels the impulse to the AV node, and at the AV node there is an AV nodal delay of 0.1 second. Okay. And after that it traverses via bundle of His to the Purkinje fibers for ventricular depolarization. Okay. But starting from the SA node, the impulse will travel bypassing the AV node to reach the ventricular muscles, to reach to the ventricular fibers. So, what will happen? The AV nodal delay will be bypassed here. So, in case of WPW syndrome, the AV node delay bypassed through a special circuit called as bundle of Kent. Bundle of Kent. Okay. Now, so what will happen to that ECG? Because there is no resistance while passing with the bundle of Kent, the atrial depolarization follows by the ventricular depolarization. There is no delay in between the P wave and QRS complex. So, starting from the P wave, the QRS complex will be immediately started. Okay, the ventricular depolarization will be immediately started. So, the normal ECG what exactly looks like, it will not seen in case of WPW syndrome. This is the P wave, the normal PR segment, then QRS complex, then T wave. This is normal ECG, but in case of WPW syndrome, the P wave followed by QRS complex, then T wave, WPW, and because of this pattern what looks like the delta, this is called as delta waves in ECG. So, this is one MCQ that has been frequently asked in the NEET PG examinations in an INA-CET. The delta waves in the ECG will be found in WPW syndrome. Okay. Now, what are the different ECG features in WPW syndrome? ECG features. Here One obvious thing is that short PR interval, okay, prolonged QRS deflection, with slowed on of stroke, okay, but starting from the P to the J point it will remain normal. So, PJ interval is normal, okay. This may as a MCQ question. The PJ interval is not changing in case of WPW syndrome, okay. Another feature of that WPW syndrome is that there is always attacks of paroxysmal atrial tachycardia, okay. There is always attacks of paroxysmal atrial tachycardia which will be seen in WPW syndrome, okay.